time this morning. And some of you may know me, I'm an adult neurologist. I work at the National Hospital for Neurology and Neurosurgery, which is part of UCLH in central London. And I also do clinics at the Epilepsy Society site in Chalfont St Peter. Some of you also may know the centre we have there. I spend about half of my time in face-to-face care for people with epilepsy, and the other half of the time I'm doing research. And the two really are the same in my mind. We're all trying to understand more about the epilepsies in general and Dravet syndrome especially, and to use that information to try and do what we can to improve things for people with Dravet syndrome. So I'm going to be talking about adults with Dravet syndrome. I'm an adult neurologist. I don't see children. I see people from the age of 17 or so upwards. And I'm going to tell you a little bit about my experience of seeing people with, seeing adults with Dravet syndrome. And then happy to take some questions. So I'm going to try and share my screen now. So hang on a second. So a lot of this is going to be obvious to a lot of people, but some of it I think needs saying. And some of it may come as welcome or unwelcome news to people who may be listening who've got children with Dravet syndrome. So I think there are some things that are obvious, but important to point out. Most children with Dravet syndrome become adults with Dravet syndrome. That sounds so obvious, yet it seems to me that so much of the health and social care systems don't seem to realize that. There are so many things that change at the age of 17 or 18 when transition takes place, and people fall off the edge of a cliff. Sometimes it feels like. And I guess that's partly what this session is for and about. I'm sure that many of you who see pediatric services will be very used to having integrated care with perhaps multidisciplinary clinics with, I don't know, occupational therapists, speech therapists, psychologists, all sorts of people available in the same clinic. You may be less happy to hear that when people become adults, that's often lost. And trying to set up a multidisciplinary clinic in adult practice is actually really hard. No matter how much we might all want it, it just seems very difficult to do. So that's something that's obvious, but I think important to know. I think one of the things that doesn't help in all of this is that Dravet syndrome for many years was known as severe myoclonic epilepsy of infancy. And so I, as an adult neurologist, used to think, well, I don't need to know about that, do I? It's severe myoclonic epilepsy of infancy. Why bother? It's not something that affects adults. And it wasn't until many years, probably 20 years after the description of Dravet syndrome, that really we began to think, actually, well, obviously people with this condition grow up into adulthood. And so we need to be thinking about what happens in adulthood. And I think changing the name to Dravet syndrome was a really important step, because that meant that it was something that wasn't so obviously limited to infancy, which of course, as you know, isn't the case. So, but what that meant was, I think, that there was much less education of people who might now be adult neurologists about Dravet syndrome, about its existence, about what the features of Dravet syndrome what might be, and about the care that people with Dravet syndrome might need as adults. And I think that's something that still we see, because although there is growing awareness in adult services, especially adult neurological services, about Dravet syndrome, and actually the charity itself helped with this with a day we had for adult neurologists probably almost 10 years ago, I think now. It's still the case that there are a lot of people who don't really know that much about Dravet syndrome in adulthood in the healthcare services. And that's something I think that we need to address. Because what this can mean is that there are difficulties at transition. So from going from people who know a lot about the condition to maybe people in the services who are much less familiar with it. And that makes transition, I think, sometimes a little bit difficult for people. And what complicates all of this is that we really have limited information on what happens in adulthood. We don't really know what the long term holds, and you'll see some of that from what I'm going to say later in this talk. And what we really need to do, and I think that's something that we can do together, and something that I think Dravet Syndrome UK really could I think, be part of and lead is to gather more information about what happens in adulthood. It's a way, I think, of also empowering people in this situation. So I'm going to give you some examples now of people I see with Dravet syndrome. So the oldest person I see is actually 70 years this year. And the diagnosis was made at the age of 59. So I'd been seeing this gentleman, actually I took over his care from one of my colleagues, and I'd been seeing him for a few years. There was no diagnosis. The list of things that he had at the top of the letter was treatment-resistant epilepsy, intellectual disability, wheelchair use. These are just descriptions. They tell you nothing about what condition the person has. And it wasn't really until various other research was undertaken around the world that allowed us to think, well, actually, what is going on here? Why is he losing his ability to walk? Why is he losing the few words that he had? Why is he having swallowing difficulties? And when we went back and looked at his original notes, which we actually still had, and we still have, he's got a series of case notes that literally are more than a foot thick. And when we went back to the very first set of notes, the diagnosis there was of vaccine encephalopathy. And by that stage, research had shown that most people who carried this diagnosis actually had Dravet syndrome with a mutation in SCN1A. So at the age of 59, we made the diagnosis, did the genetic test, and found that he had a stop-gain mutation in SCN1A. And that was important at that time because so few adults with Dravet syndrome had been found out or had been diagnosed, that it was really important that we had additional evidence to substantiate the diagnosis. As you know, you don't have to have the genetics to make the diagnosis, but at that point, in somebody of this age, I think it was important. So what's this done for him? Has it made any difference? Well, I think it has actually for him as an individual. So when I had been seeing him, his seizures were still frequent. He had a convulsive seizure at least once a month. He was beginning to lose the few words that he had. He had to use his wheelchair all the time, and his swallowing became unsafe, and he ended up with a gastrostomy. And he had lots of investigations for all of these things, including some under my own care. But when we finally made this diagnosis, we realized that there were things that we could try to do to help. And so we took him off carbamazepine, which is probably the most important thing that we did in terms of management. We built up various other drugs, valproate, levetiracetam, and it stopped his seizures. And for the last 10, 11 years, he's only really had seizures when he's otherwise unwell. So if he gets a chest infection, which he does get a lot, then he may still have some seizures. But otherwise, he's free of convulsive seizures. And this, of course, helps because it's not nice to be having those seizures, because it's easier to provide care when you're not having to worry about the seizures all the time. And it's led to an improvement in speech. So having lost the few words that he has, he's now speaking. And you may have heard, some of you may have heard this history before, but he can tell me what sits at his bird table. So he can tell me that there are greenfinches, blue tits, robins. He can tell me there are rats in the garden and pheasants at the base of the bird table. He can ask me questions. So he doesn't so much now, but he used to ask me how I was. And for his family and for him, this is a huge change from going from not saying anything, hardly anything, for the several years leading up to the diagnosis, to now being able to say things again is a huge change. And for the last 10 years, this has been a real education for me in trying to see what happens in Dravet syndrome as people get really much older. So he's the oldest person I know of in this country. You may know of others, but in this country, he's the oldest person I know of with the diagnosis. And it's interesting to see what's happened in the last few years. So his seizure control has remained excellent. In fact, I had a teleclinic appointment with him just quite recently and with his carers. He's not had any seizures now for over 2 years. But his speech has become more difficult to understand, even to people who know him well. It's of course difficult to know how much of this might be Dravet syndrome, how much of it might be aging on top of Dravet syndrome, what else might be going on. It's really difficult to know because this is one person, and it's very difficult to draw conclusions from looking at what happens to one person. But it has made a big difference to him, making this diagnosis even at this late age, because it means that seizure control has improved. And that's the one thing that we can still try to do. And what that has also meant is that he's having fewer admissions to hospital. And that's a really important step forward, I think. And I think it would be fair to say that his quality of life has improved once the diagnosis was made. So I see now a number of people who are over the age of 18. There are 7 people I see who are over the age of 40, quite a few people in their 50s with Dravet syndrome. So it's clear that people with Dravet syndrome can have seizure-free lives even later in life. It is possible. And I'm not sure how much of this is well known in the Dravet community and how much of it is well known in the neurological community. And that's something that we're trying to address by writing about people with older people with Dravet syndrome and putting this information out there so that people can realize that actually it's important to think about adults with Dravet syndrome. It's important to keep trying to do things because it can make a difference even later in life. So I should emphasize that this isn't a formal study. This is really just a series of observations that I've made in clinic over the years by seeing people with the condition. And what's clear is that we don't understand much about Dravet syndrome in adulthood. And what's also clear is that something simple you might think might tell us how people are going to do isn't so simple. So you know that there are different types of mutation, for example, in SCN1A, and you might think that a more severe mutation would have a more marked effect and that people might have a more severe condition. Doesn't seem to be the case. So for example, the gentleman I just described who's 70, he's got the worst kind of mutation, if you want to put it like that. He's got a stop-gain mutation, and yet he's doing relatively well. And that's after a lifetime of convulsive seizures and recurrent episodes of status epilepticus because he was on the wrong treatment. He's not had status, he's not had many seizures since we've put him on more appropriate treatment. But it doesn't explain, I think, the whole picture. What is clear is that everybody I see has a degree of intellectual disability, and some people have had some degree of progression of that in adulthood. On the other hand, most people haven't. So this is obviously not on formal detailed evaluation. This is on what families tell us and what I see in clinic. There isn't a marked deterioration. And in fact, some people, I think 8 I've listed here, we've seen that there's been an improvement in speech following the diagnosis and medication changes. We've seen that there's been improvement in seizure control. I'll talk about that in a minute. 11 people have developed other problems. They've developed swallowing difficulties. We know this can happen at different times in Dravet syndrome. 5 people have needed changes to their diet, going from a fairly ordinary diet to a pureed diet. And 6 people have required a gastrostomy. And I have to say, it's a big decision, obviously, for families to think about having a gastrostomy. But invariably, every family that I've seen with this has, in the end, felt that it's been the right thing to do because it's led to an improvement in nutrition, hydration, and in the ability to ensure that medication is regularly administrable. So, you know, sometimes there might be difficulties, people might refuse to take their medication. That's not uncommon in my experience in Dravet syndrome and other conditions. But when there is a gastrostomy in place, that anxiety is removed. So it's a difficult thing, it's a big thing, it doesn't suit everybody, but it does seem to help when it has been done. 6 people that we've seen have experienced deterioration in motor function. Again, this is not a detailed evaluation with lots of scales and tests. This is in terms of ability to walk, need to use a wheelchair, which is increased for some people that we've seen. In terms of seizures, I think there's a belief, I think, out there, and sometimes I think some of my pediatric colleagues may also feel this, that seizures become better with age. And I think that can happen, and some of you may have that experience, but it unfortunately doesn't always happen. Now, I've got a biased experience here because I'm an epilepsy specialist, so the people who refer to me are by and large people who often are still having seizures. Not always, but often. But we do see that seizures can continue. It's not the case, unfortunately, that as people get older, the seizures stop. They can get better, the myoclonus may get better, but they don't stop altogether, or they don't have to stop altogether. So most of the people I see still have convulsive seizures. Many have myoclonic seizures, but people tend not to record those so much. So we don't have detailed information on that. What we also see is that seizures can become of focal onset rather than of generalized onset. So especially frontal seizures may occur. And the other thing we see is that the pattern may change, so that seizures tend to occur much more from sleep than they do from wakefulness. So this is good and bad, as you probably know. It can mean that they are a little bit less disruptive, but of course it does raise other concerns, because we know that seizures, and especially convulsive seizures from sleep, can increase other risks, of which I'm sure that you're all aware, including, for example, the risk of sudden death. So this is something that we need to be thoughtful about in terms of what happens with seizures. The response to medication I've talked about a little bit already. Sometimes seizure control does happen with medication changes, as you saw from the very first gentleman whose case I presented, but not always. And certainly I still see many people for whom we still need to find other treatments. And for a number of people now in adulthood with Dravet syndrome, we've tried cannabidiol either through the early access program or now through a slightly simplified system. And while some people have had some benefit, I have to say that in our experience in adulthood, cannabidiol has not been a miracle treatment. It hasn't stopped seizures completely. In our experience, it's still a relatively small group of people, so I wouldn't say this is what everyone should think, but this is what we are seeing in our small group of people with Dravet syndrome. It hasn't stopped seizures completely for anybody. And that means that we're still looking for treatments. By the time that people with already diagnosed Dravet syndrome get to me, they've often tried everything that's available. And then it becomes obviously very difficult to think about other things to try. And we're certainly looking forward to newer agents becoming available, for example, fenfluramine. And I'm really looking forward to that becoming available and to trying it for the people that I see with Dravet syndrome. But at the moment, as you know, it's not something that I can prescribe. So I want to say a little bit about new diagnoses still being made in adulthood. I guess that might not apply to many people who are on the call, but we are still seeing people in whom the diagnosis was missed in childhood for various reasons and is now only being made in adulthood. I just want to give you one example. The graphic on the right of the slide is deliberately small. It's just a timeline, really, to give you an idea. Those are all the things that have happened to him. This is a gentleman who's 53 now, and the diagnosis was only recently, 51, I think I should say. The diagnosis has only recently been made. And this list that you can see on the left-hand side of the slide, these are the diagnoses that he carried over many years. So over the last few years, for the records that we've got available on our electronic system, the diagnosis has been of generalized tonic-clonic seizures, spastic quadripresis, and severe learning disability. These are descriptions, they're labels, they're not really a diagnosis, and they don't give us any clue about what this patient might actually have. And actually, we stumbled upon the diagnosis by chance through a large-scale genetic screening program. And we found that he had an SCN1A mutation, a stop-gain mutation, and we went back to think, actually, does he have Dravet syndrome? And when we finally got hold of the paper notes, we got back to the very first letter, and the very first letter is still in there, photocopied. It's a fantastic history of what's happened over the years. The very first diagnosis he had was of myoclonic epilepsy. That was back in 1970 something. No, actually, hang on a second. Do my maths. I can't remember now, something, before Dravet syndrome had been described. So I don't think we can blame anyone for not making that diagnosis because it hadn't been described. But the description was of myoclonic epilepsy, compatible with Dravet syndrome. And then the diagnosis became epilepsy, hyperactivity, and mental retardation. And then the diagnosis became spastic quadripresis, cognitive impairment, and epilepsy. And you see the last diagnosis that I told you about first. And now the diagnosis is of Dravet syndrome. And you can see how those diagnoses have changed over the years for no good reason. They're just descriptions. And this is a real lesson for my colleagues in the world of adult neurology. because many of us in our epilepsy clinics will see people with these features, with spastic quadriparesis, with intellectual disability, with seizures that are not responding to treatment. And without that early history, maybe parents aren't available, can't come to clinic, the early notes are lost. Without that history, people won't be thinking about a diagnosis of Dravet syndrome. You don't have time in a 15-minute clinic appointment with carers who might not know the patient to go back to the early history and make that diagnosis. So one of the things I think it's important to do is for us to write about this and tell our colleagues in adult neurological services about these histories, about these cases, because then people will begin to think, well, actually, maybe this person with difficult to treat epilepsy might have Dravet syndrome. And that's worth finding out because, as you see, it can make a difference to the treatment from the very first person I told you about. So, I think there are some important lessons in all of this. We don't know how many adults there are with Dravet syndrome. We don't know how many people out there have got Dravet syndrome and the diagnosis has never been made. I keep talking to people about studies we should do to try and work this out, and I'm still interested in doing that. But for one reason or another, it seems not yet to have happened. What this means is that we don't know much about the course of Dravet syndrome in adulthood. We're only kind of twigging to this diagnosis now. I've been thinking about it for, I guess, 10, 11, 12 years. And I like to think I'm somebody who's interested in genetic epilepsies. And actually only started beginning to be interested in that with that very first diagnosis. So we don't know much about what happens in adulthood. But we do know that it's still important to try to get seizure control, no matter how late the diagnosis is made. It's always worth trying to do that. It's one of the few things that at the moment we are actually able to do. Of course, there's lots of exciting stuff going on about gene therapy and upregulating SCN1A expression and all of these things. It's really exciting stuff. And hopefully it'll all be something that we're able to do on a regular basis. But right now, we can't. Right now, about the only thing we can do is to try to bring seizures under control. And that's always worth trying because it can make a difference to people's quality of life. Unfortunately, we know that sometimes whatever we try doesn't work. People continue to have treatment-resistant seizures. And all of this tells me that we need to know more. We need to know more about adults with Dravet syndrome. And I'd be really interested in working with Dravet syndrome in the UK to try to do that, to get more information in adults. Everything that happens in Dravet syndrome, it seems to me, and understandably, has focused on children, which is right. We learn a lot from that. We need to do a lot then. But of course, a lot of the children we see will become adults, and we need to know what happens. So there isn't, to my knowledge, a formal recommendation or set of guidelines in the UK for management of Dravet syndrome in adulthood. I might be wrong, and maybe they're being developed, but at the moment, I'm not aware of that for adults. I would say the following things. I think adults need to have neurological follow-up. They need to see a neurologist. I'm not saying they all have to see me. I'd very much like to see lots of people with Dravet syndrome. I can't see everybody with it. And of course, we need that expertise across the country, not just in one place. People sometimes can't get to where I get to, for example, or their local authorities won't allow them to be sent to us. So everyone needs to know about this, all adult neurologists, and we need everyone with Dravet syndrome to have neurological follow-up in adulthood. There are lots of things to think about. I've just touched on a few. Seizure control, drugs and their side effects. Sleep. We're doing some studies now on sleep in adults, and we're seeing that sleep is often disrupted in adulthood. Sometimes as a result of seizures, but sometimes separately. Behavioral issues can become worse or better. I have to say that for most people with Dravet syndrome that I see, behavioral issues aren't so much of an issue as perhaps they had once been. Still sometimes, but less it seems. Eating and swallowing, on the other hand, can be. Loss of appetite is often an issue, and sometimes, as I've described already, having a gastrostomy can make a big difference. But the one thing that I think that does need to happen is there needs to be a regular question in clinic appointments, a regular thinking about whether people are having swallowing difficulties. Are people coughing or choking or spluttering when they eat? That can be an indication that swallowing isn't right. And that should lead to a proper formal speech and language therapy assessment. Now, that might show that everything is fine, or it might show that a pureed diet is needed, or it might indicate the need for further follow-up and possibly a gastrostomy for safety. Related to all of this, of course, is weight. So most of the people I see with Dravet syndrome are probably underweight or slim. And I think this is something that, again, a gastrostomy can help with. And overall, good nutrition and good hydration is important. For example, if you think about bone health in the longer term, many people with Dravet syndrome may be less mobile. They may have less opportunity to gain vitamin D supplementation through exposure to sunlight. Their bone health may suffer, and therefore we need to think about that and nutrition as well. And of course, valproate and contraception becomes an issue. You know, there's been a lot of attention paid to valproate recently. I think some of the things that the MHRA have brought out more recently are a little bit more sensible and helpful, so that we don't have to go through pointless questioning when it's not really going to be an issue for some people, some young women. We have to think about SUDEP. Again, it's very limited experience. I'm not claiming this to be fact, but over the years that I've seen people with Dravet syndrome, and I'm touching wood at the moment now, I haven't seen SUDEP in the few people that I have seen with Dravet. That does not mean it does not happen in later years. I don't think we know, but I think it's something, again, that we need to address and think about. And maybe, again, work together to try and work out what's happening, gather that information. So all of these things, I think, can still mean that quality of life can be preserved, can be improved, even later in life for adults with Dravet syndrome. Unfortunately, I don't think that we necessarily always have the best resources available, or the sorts of clinics that I know that can take place in pediatric services. As I was saying earlier on, we often don't have joint up clinics. We don't work with occupational therapists, social workers, speech therapists in our own clinic. I'd really love that to be the case, but it doesn't happen. I don't have a clinic just for people with Dravet syndrome, for example. I see people with Dravet syndrome in my clinics for people with epilepsy. I think it would be something really interesting to do and important to do, to build up a center of expertise and multidisciplinary input. But that's something that I think we really need to think about, work out how to do, and I think work together to try to make that happen. And underpinning all of this, we've got to have more research. We've got to gather that data. That's the way that I think we can empower families, the organization, all of us, including healthcare providers, to look after people better with Dravet syndrome. And what we see is that there's a big focus, of course, naturally, rightly, understandably, on children. But if you take part in meetings, you often see that the language that's used is children with Dravet syndrome. And I think we need to be talking about people with Dravet syndrome, because that means that we don't ignore adults. And I think that happens too often.
Thank you so much. Yeah, I've personally learned so much from that. It's been incredibly informative. So I'll hand over, Fiona, to you.
Thank you very much. Thank you, Helen, and thank you, Sanjay. I personally found that really interesting, and I'm already thinking about ideas of building the multidisciplinary centre that Sanjay says is needed and how we can try and make that happen in the next few years. I'm now going to try to share my screen, but apologies, this is a new focus for me. Ah, there we are. That's the one. Has it come up? Can you see it on the screen now? Right. Now I just need to start the slideshow. This is like a whole new thing for me. Oh, right. I'm going to talk to you about the practical elements. So I can't claim to be as august as Sanjay, but I've spent 20 years representing disabled adults around health, social care and education rights. So this is just a very short introduction to the rights that your young people, largely I know I'm speaking to parents, although I can see some young people and adults in the room, in some of the rooms as well, about the rights that you have for access to social care and healthcare which is related to social care. So that's not Sanjay, that's sort of care and support, the sort of carers that you would have coming into your home at the moment, hopefully as children. So firstly, there are a series of duties to stop young adults falling off the cliff edge. As Sanjay's talked about, the transition from children's services to adult services in respect of both health, social care and education was universally acknowledged to be hopeless. So in 2014, the government changed the law to, in effect, it creates a complex series of provisions, but what it basically says is any provision you get in respect of social care pre-18, you will continue to get unless and until it's reviewed. The idea being to stop people falling off the cliff edge. The local authority do, however, have the right to reassess your needs and consider them again when somebody becomes 18. Now, the first question to ask is, when should adult social services start that process? All your children, I can't imagine any of the children and young people who have Dravet syndrome are likely not to meet the criteria for social care needs under the Care Act 2014. There may well be some very small exceptions to that, but the likelihood is that the level of quality of impairment of your lives, either intellectually or socially or in terms of self-care, is likely to be enough. So every young adult has a right to a social care assessment if they are likely to have needs. And the statutory guidance says if you're already getting help from children's services, as most of your children will be, you will be entitled to an assessment to see if you should have adult rights. They then must carry out an assessment or tell you why they're not going to do so. And there is a duty not just to assess your young person, but also to assess parents, if you are carers, and young carers. So that is largely siblings. And the guidance about carrying out assessments makes it absolutely clear that you can't assume that what's happened when somebody is a child will carry on until they're an adult. In particular, in respect of, they often won't have somewhere to go 5 days a week because school might have stopped, further education might have stopped, training might not be a possibility. So therefore, there may well be a significantly greater burden, particularly on parents or those with whom the young person lives. So when to assess? Now, the current guidance doesn't say you have to assess everyone at 16, you have to assess everyone at 14. But what it does say is you should carry out this assessment where their needs as an adult can be predicted reasonably confidently. And I do know I've spelt there the wrong way on that slide, for which I apologise. If somebody has an EHC plan, the process should begin in year 9. So people should be starting to think about it in year 9. The guidance sets out a number of factors to be considered about when you should start the planning process, which should include, are people likely to move out? Can they continue to live with their parents? Largely people live with their parents. How long is it going to take to make an assessment? And how long is it going to take to plan adult care? Now, my practical experience is not long enough is given. I see quite a lot of people at this transition stage. I would say that for the sort of complex needs you're looking at, I would say it's going to take 2 years, I reckon, to get a proper package up and running, from first thinking about it to sourcing the provision, finding the care package, outlining it. Practically, particularly if you're looking at somebody moving out of the home at 18 or 19 or 20, that is often a 2-year process, because often they have to find and buy somewhere for your young person to live. So I would say you cannot start lobbying early enough. in my view, and thinking in your own minds about what would you like to happen at 18 plus. Now, a number of your children may well go into residential care, or they may well during their teenage years, because the complexity or challenges of their behaviour or your ability to cope with them after a childhood of continuous support might mean that they end up in a residential care setting. But I'm talking about those young people where that isn't the case. But even if that is the case, before they get to 18, there's no presumption that that continues after 18 or will continue into adulthood. And certainly the idea is that young people, even with very complicated needs, should try and be supported in their own communities rather than living in residential care settings. Now, how far that's practicable is another issue. So you get an assessment under the Care Act. It should involve anybody who looks after the person. So if they're living away from home, it should involve the residential setting, you, any other adult, anyone else who's involved in their life. The good thing about the Care Act 2014 is it has made various things compulsory, which is the assessment has to be in writing, the assessors must have the skills, competence and knowledge to carry out the assessment. Now, for your children, that is a real challenge because most social workers won't have come across anyone with the complexity of epilepsy needs. So you would want to be lobbying, if you're a parent, to have them probably liaise with your clinical support or with your paediatric team, who, even if they didn't know anything about Dravet syndrome before they first met you, are likely to know quite a lot about it now. There's also the right to have an independent advocate if somebody is likely to lack mental capacity. And I'll come on to talk a little bit more about the Mental Capacity Act later. So there is then a duty to provide care, but only if individuals are unable to achieve 2 or more of the outcomes and they are likely to benefit from services. Now, again, I've set the outcomes out on the slide. It's, well, I don't know. Children and young people with Dravet syndrome, I know, vary. I suspect most of the children and young people who have Dravet syndrome will be able to not be able to do, or not be able to do without assistance, as I'll come on to explain, 2 or more of those things. So some of them are obvious, like nutrition, managing toilet needs. Others are about developing and maintaining family relationships and ability to access work, training, or education. And they must be either unable to achieve the outcome or unable to achieve it without assistance, or if they do it without assistance, it either causes them significant pain, distress, or anxiety. It may endanger themselves or others, or it will take significantly longer than expected. So it's not just you can't do it, it's if you do it, you might hurt yourself. So certainly those with a significant impairment of their intellect, which may be some of the group with Dravet syndrome and motor difficulties and things like that, you are likely to be unable to do those things without a significant amount of assistance. And that it will have a significant impact on your well-being. Once those needs have been identified, and again, helpfully, the legislation says there has to be a care and support plan, which has to say what happens, when it happens, how much money you get, who's going to provide this, when they're going to provide this, and that all has to be done in writing. Once that has all been set out, then there is a duty to meet those needs, irrespective of financial resources. So you should have a lovely document which says, I don't know, I'm going to use Arlo as an example because he's the young person I know best. Arlo should have 24/7 care round the clock from super carers, and Galia should be paid hundreds of thousands of pounds a year in order to be provided it. So that's what it should look like, or a variation on that. So you should be getting care and support plans that should say who's going to be doing the care, when is it going to be done, who's going to pay for it, what's going to be paid for, how often is it going to be reviewed. They often don't look like that in practice, but that's what they should look like. So, and I've set that out there. And in particular, a lot of you will be getting direct payments, or you might be using them yourself. There is a duty to identify those. And also, in all cases, there should be a personal budget set out. All of you have a right, all adults have a right to a personal budget. What provision can adult social services make? Well, pretty much anything, save for health needs or things which are primary health needs. I'll come on to explain this. This is part of the ridiculous divide there is in health and social care in this country, which has resulted in endless fighting about who pays for what, and this is part of this. So if it's a primary health need, the social services cannot provide it by law. The law says you can't do it, and they cannot provide accommodation if the only reason they are doing so is because somebody is homeless under the Housing Act 1996, i.e. they haven't got anywhere to live, and the only reason that they need accommodation is for when they have to live. Accommodation can be provided if it's part and parcel of the social care services. So domiciliary care, what we call as lawyers call domiciliary care, i.e. people coming into your house, laundry services, counselling, social workers, goods, facilities, transport to education, days out, trips, holidays, all those things can be provided because there's no list of what's provided or what isn't. It's whatever the person needs, and that can either be services for the disabled person or services for the carer if that's what's required. However, although there is a right to charge in children's services, most children don't ever fall under, it never really becomes an issue. For adults, local authorities are under a statutory duty to charge adults for those sorts of services. And so therefore, your young person will have an assessment of their financial needs. So certainly for those of you who might have trust funds or independent trusts or things like that, I know some people might have that or might be thinking about that. You would need to undertake some quite careful planning of that in order to make sure that you don't inadvertently disadvantage your child or young person in accessing support and services. There are some minor exceptions where they don't have to charge, which is community equipment, so aids for daily living, and where the adaptation of your home is less than £1,000. Well, as you can't get a builder to kind of change a skirting board for less than £1,000 these days, that isn't going to be very much. Also, for a very small number of your children who may well demonstrate severe challenging behaviour, you may well be in the unfortunate position that your child may well have, by the time they reach the end of their teenage years, been admitted to an inpatient psychiatric facility. If that is unfortunately what happens, when your young person comes out of that psychiatric facility, the care provided to them related to their mental health needs is free. And if the NHS is responsible for the provision of social care services, which I'm going to come on to talk about, then there is no charging. So I know that a lot of people are worried about COVID and about the changes that might have been made, because what has happened is the government has introduced in the Coronavirus Act a right, in effect, for a local authority to not meet adults' needs, not children. Children needs exactly the same. They have to meet children's needs, but adult needs. Now, I have shared a presentation with Galia and the Dravet Syndrome Association, which a colleague of mine, Stephen Naffler, wrote about this, which sets this out in much more comprehensively. I don't have time to go through it in any great detail. However, in effect, it can only be done if there's nothing else that can be done. A local authority, what they should do first is try and say things like, well, maybe we don't do a review right now, maybe we don't do a assessment, maybe we just do a quick assessment before they stop providing services. And they only stop the provision of services if work for completed, that it would lead to those services had to be provided. The reality is that most of your children and young people are going to fall into the urgent needs. And in any event, those sorts of decisions about reprioritising services can only be taken by the Director of Social Services in the local authority, and it has to be reported to the Department of Health and Social Care and has to be reviewed once every 2 weeks. There are a couple of authorities who have exercised these rights. Birmingham is the obvious example. But the vast majority of local authorities have not as yet gone down this path, largely because when the legislation was passed, there was an expectation of even greater numbers being unwell, and therefore there being an even greater need for this, largely because there wouldn't be the care staff in place to provide the level of service provision and support. So I would say there's been a lot on the Twitter sphere and in social media about this. Yes, it does provide a dilution of rights and duties, but the message from central government very much is, unless you absolutely have to, it should be business as usual for the provision of health and social care. And I think there has been a degree of scaremongering about the impact of this. Now, I can't say in the long term that it might not be problematic, but I would certainly say that the government aren't giving any local authority a green card to reduce services unless it's absolutely necessary. And I think the courts will be very quick to try and stop anything other than legitimate derogations from a local authority's duties in this regard. NHS funding, just briefly to identify, a number of your young people may in fact qualify for what's called continuing healthcare funding. Now, some of you will get that as children. There is a distinction between children's continuing healthcare funding and adult continuing healthcare funding, not so much in terms of the assessment, but by what it means financially. Basically, if your young person is deemed to have a package of care of which the nature, intensity, complexity, or unpredictability means that the quality or quantity of care falls outside the ambit of social care, that therefore means it meets a primary health need. Now, if you don't understand what that means, you're not alone. It is an absolute mess, but it's a mess that everyone's willing to live with because it's ambiguous enough to deal with a number of different situations. There is a decision support tool. For those of you who have continuing healthcare as children, you will already have gone through this. There's basically a tool which is used, and it's only a tool. It's not a definitive decision, which says if you've got particularly high needs in a number of areas, things like nutrition, toileting, behaviour, breathing, all those sorts of things, feeding, all those sorts of things, then you may well qualify. Now, the reason to qualify is because the NHS is not allowed to charge you for those services. So once you are once you fall into the bracket of somebody who has continuing healthcare funding, the your local CCG, clinical commissioning group, would be responsible for the package, both of your healthcare, but also of your social care related to your healthcare, and would be responsible for funding it. And they could not charge you for that, for the health and the social care element of any package. So that's why there are often disputes, certainly that I've been involved with, between local authorities and CCGs about whether somebody does or doesn't qualify for continuing healthcare. But that's the main advantage, is financial advantage, really. But what I should say is neither social care nor the NHS are responsible for providing what's called ordinary housing facilities. So for example, Chalfont, where Sanjay is talking about, or St Piers or St Elizabeth's, which I know have kind of 19 to 25. Those are specialist residential care home placements. They would be paid for by social services or by health or by education or by a combination of them. If, however, what you really want is somebody to live in a sort of a house or a flat round the corner from you and have carers come in all the time, that's unlikely to be specialist accommodation, and therefore that will be ordinary accommodation. Your young person will be considered to be somebody in priority need, and therefore if they have nowhere else to live or they don't have suitable accommodation, but bear in mind suitable accommodation is a pretty broad concept, so it hasn't got to be super tip top. At one stage they said it's a bit like Diogenes' tub. Now most people don't know who Diogenes is, but basically he lived in a hovel in 4th century BC Athens, and there's case law which suggests that. But certainly for those with disabilities, the court and everybody looks more carefully. So it may well be that your young person qualifies to be on the housing list, they will be a priority on that housing list, and therefore they may well qualify for social housing, whether from the local authority or from a social housing provider or payment of a private tenancy. Most people who live in what's called supported living, shared lives placements, CAPS placements, live there by way of being paid housing benefit for the accommodation side and getting money from social services for the social care side. Do not forget, housing benefit is being abolished, so therefore they will get universal credit. So they'll get one sum of money, which part of which is meant to be dealing with their housing costs. This talk is not the place to discuss universal credit. In and of itself, that would justify a whole hour and a half talking about how you claim universal credit and what it all means. The next subject that I'm just going to touch on briefly is decision making after 18. Lots of parents and children I know, and lots of parents get very worried about what's going to happen to their child when they reach the age of 18, and they think, oh my God, suddenly social services are going to swoop in, take control, and I don't want that. I still want to be in charge of my child's decisions. Well, there is a way in which that you can have that, which is a deputyship under the Mental Capacity Act. Now that is only relevant if your young person lacks capacity to make decisions. And the Mental Capacity Act makes it absolutely clear that they may well lack capacity in some ways, for example, to make decisions about their money, but that doesn't mean that that therefore means that they lack the capacity to make decisions about where they should live, what sort of care they should get, who they should see on a day-to-day basis. So when you're making a decision or thinking about whether your child or young person over the age of 18 can make a decision or not, it's not about can they make decisions generally, it's about can they make this decision at this time. And a lack of capacity is either not being able to understand the information, not being able to retain it. Most people fail the capacity assessment on the ability to use or weigh the information. So they might be able to tell you that they like the blue house and not the green house, but they wouldn't be able to tell you why. Or they might say, I like the blue house because I like the colour blue, or something like that. So very often people with intellectual disabilities in particular, and I know that some of your young people will have intellectual disabilities, some won't, and the variety and scale of it I know varies wildly, but often they're able to understand concrete things. So do you want to go and see Dahlia or do you want to go and see Ollie? But they won't be able to understand, would you like to go and see your cousin who you haven't seen for 2 years on a Saturday in 2 weeks' time? Or they might be able to understand, do you want to go and live in the house with the blue duvet cover or the green duvet cover? But they're unlikely to be able to articulate anything more than it's got a blue duvet cover or a green duvet cover. So that's where a lot of people with intellectual disability fall down, is because they can't weigh those choices up in the way that we would be able to if we were thinking about where to move. And as well, we often ask a lot of people with intellectual disabilities in terms of abstract choices. I'm not sure if you said to me, do you want to go and live in Croydon or Guildford? I'd be able to make that decision on any rational basis. Largely be about, I suppose that may well be seen as rational by some ways. So I've talked a little bit about lack of capacity. Now, if your young person lacks capacity, then people have to act in what's called their best interests. And there's a checklist under the Mental Capacity Act, which is the act which governs decision making for those who lack capacity, in effect saying you have to take into account which is you have to take into account anybody who looks after them, what they say, or who has a lasting power of attorney. But the decision has to be made taking into account all the circumstances. So the likelihood is that all decisions should be made in someone's best interests. So if social services are involved in devising care and support packages, they should be looking at, well, what's in someone's best interests. If there are disputes about where someone should live, those are the sorts of things where you would look at best interest decision making. If, for example, there was a family breakdown and everybody was fighting about who should see whom and when, again, that's the sort of thing that should be happening. Now, some parents are like, well, look, I'm not happy about this. I want to retain the control that I've had until my child is 18. Can I do that? Well, in some circumstances, yes, but I must stress it's few and far between. There is something called a welfare deputyship, which enables, in effect, the deputy to make decisions on behalf of someone. However, you can't make decisions about their ability to have sex, their ability to marry, or what contact they have with other people. So therefore, the three issues which can cause lots of difficulties, which is young people getting involved in unhappy / disastrous / positively harmful relationships with members of the same or opposite sex, or engaging in unwise behaviours, shall we say, you can't do, even if you had a deputyship, you couldn't physically stop that. And you can't also basically consent to somebody dying early for obvious reasons under the deputyship. But what the law says is a decision by the court is preferred to the appointment of a deputy. So if there were to be, the idea is meant to be that everyone gets on swimmingly and everybody agrees, and that all decision making for adults is collaborative and informal. If you fall out, there is a route to go to the Court of Protection. However, obviously that's discouraged, and it's really only in cases where there's been a massive falling out, usually either between family members or between the local authority and a member of the family about future care provision, or there is a suspicion of abusive behaviour by a family member or by a carer, that the Court of Protection tends to become involved. And the court makes relatively few personal welfare deputyship applications. There are about 375 appointed a year, in comparison to around 15,000 for properties and affairs. Now, that's partly because far fewer people apply, but it's also because far fewer, it gets made quite rarely. Now, a group of parents, the most famous of which is Rosa Monckton, the mother of somebody called Domenica Lawson, who's a young person with Down syndrome, made an application to the Court of Protection last year saying, look, I want some clarity. I would like to be the welfare deputy for my daughter. I don't want the local authority, taking charge in any way. What can I do? What the court stresses again is capacity is about autonomy, and disabled people have as much right to autonomy as anybody else does. So any other young person, when they reach 18, no longer is in their parents' charge. Whether in practice that's the case or not is another matter. And disabled people shouldn't be treated any differently. So therefore, in the vast majority of cases, a welfare deputy may not be needed. And in particular, what the judge said, not by a welfare appointment. It all depends on the competing factors and somebody's wishes and feelings. So if they're able to express their wishes and feelings and say, I want my mum and dad to do this, then that is a fairly powerful factor. And what the judge also says is where it can show that collaborative and informal decision making isn't working, an appointment can be made. So, or in very difficult cases. So where there may well have been, I'm thinking about cases where there may well have been a history in childhood of contact disputes between parents or between relatives, where there may well have been a long history of challenging decision making unhelpfully. I can see a situation where the court would say, look, there should be an appointment of a welfare deputy, or where there are a particularly complicated set of decisions to be made. And in reality, you can't keep going back to court every 2 seconds for those decisions to be made. A court may well say, okay, I will accept a substitute decision maker. So it's likely, or where you can say, look, we've been fighting with social services for the past 5 years. Really, we would like a welfare deputyship because they are not doing things correctly. And it can objectively be shown that that's the case. Then you may well get a personal welfare deputyship. In most of the cases that I've been involved with, you only get a welfare deputyship if either there are a series of very complicated decisions which have to be made for your young people, and actually the sorts of decisions that you may well be having to be made may well fall into that category, given the complexity of your child's health, social care and social care needs, which are at the top end of the spectrum. One has to sort of recognise that, or can be. In other, or where everybody's fallen out with each other. I've known judges who've appointed a welfare deputy where it's like, oh my God, everybody's fighting with each other so much. I just want to appoint somebody, sometimes an independent person, so I don't have to see these people anymore. And so they can, and so there is somebody who says, no, right, fair enough, you can all tell me your views, but I'm the one who's making the decision, where it's positively harming the young person. Other than that, at the moment, the court are not keen on permitting welfare deputyship applications. So it all depends on the facts of the case, but do not assume that you will automatically get a welfare deputyship order at this time for your child and young person. So that, I think, is 31 minutes and 39 seconds. That is a real whistle-stop tour. Thank you very much for listening to me. Thank you.
Thank you so much, Fiona. That was absolutely excellent. And just to say to everybody, I'm sure as I was doing, you were writing down notes from those slides, and we will be making those slides available. So thank you so much to everybody for all the questions that you have put to Sanjay. I think actually they're mostly for Sanjay at this point, but Fiona, others may have questions for you. Sanjay, have you been able to go through those questions on the Zoom chat?
I have, yes. So shall I go?
Yeah, I'll hand over to you to go through them. And then if anybody has any questions for Fiona, please do message those now.
So there were two questions related to whether medication responses might change with puberty and into adulthood, and whether drugs that maybe weren't effective might become effective, or the other way around. I think, unfortunately, we don't know. We know that the underlying genetic condition, of course, doesn't change, but obviously so many things change with transition from childhood through puberty to adulthood. And that'll be your own personal experience. You'll bounce less, you're less flexible, all sorts of things change as age takes hold. I think what we do find is that sometimes we have to try drugs that have been tried before and were discontinued for various reasons because we've run out of drugs to try. And in that case, what we tend to do is to go in detail through the previous records to work out what responses were observed, make sure we don't try something that had some terrible response, but we will sometimes consider drugs again. But I don't know that there's strong evidence that a drug that didn't work in childhood might work again in adulthood. This is still something we need to think about. I think one thing that we do think about is that focal seizures might be seen in adulthood and had not been present in childhood. And then you know that the range of drugs that we use for focal seizures is different to that we use for generalized seizures. So there is some merit, I think, in reconsidering that and thinking about drugs that may not have worked. There's a question about whether lamotrigine is good for adults. I don't think, again, that there's definitive evidence for that. We know that some people with Dravet syndrome may benefit from lamotrigine and others from phenytoin, which are drugs that in theory shouldn't work. We don't know why that is, something that a number of people are looking at. Whether it relates to seizures becoming focal rather than just being generalized, we don't know. So not a very concrete answer, I'm afraid. But I think it's something that you have to go through for each individual, and sometimes it is worth reconsidering, especially if there's not much left to try. I don't know if that is very helpful, but it just illustrates, I'm afraid, that we don't know a lot of these things. Then there was a question about SUDEP in age groups, different age groups. Again, we don't know. The focus of most of this work is in childhood, and we know about what happens in childhood. My anecdotal experience, as I said earlier, is that none of the people that I've been referred and I'm still looking after has had SUDEP, I'm pleased to say, but I don't think I'm aware of data on the risk of SUDEP in adulthood. And again, this is another hole that we need to fill to try and get information about this. There are reasons to consider that the risks might change. There's quite a few things that happens to the way that genes are expressed in the brain as people get older. So there are reasons to think that actually the risk could change, but I'm sorry to say that we don't have hard information on this. So again, I'm afraid I'm not being able to help you very much there. Somebody asked if they could have an appointment with Zoom. Yes, that's perfectly fine for somebody I'm already seeing. We're doing most of our clinics remotely now, so that's absolutely fine. And then there were two questions that were asked in advance. And one of them related to, just a second. One was, just the question was, if an adult with Dravet is admitted to hospital with coronavirus or another illness, the parent or carer might not be allowed to go and stay with them. And I'm afraid that so far, that is usually the case. So the person I look after who has the most severe condition, she doesn't have Dravet syndrome actually, she has a progressive neurological condition that we haven't been able to diagnose despite all sorts of investigations. And she has a tracheostomy and recurrent chest infections and all sorts of problems. She was admitted with symptoms of, that could be compatible with COVID. She was shown to have the coronavirus. She's been in hospital for more than 3 weeks and her family have not been able to visit. So it does seem to be the case, and it is currently the recommendation that visitors are not allowed. And this is obviously because of the risk of transmission and the risk of spreading disease. So that does seem to be the case. Whether that will change with time, I think is something that we will learn. We're doing a really intensive piece of work at Chalfont to try and look at this and what happens in terms of transmission between carers and the residents. And we might have more information about this that might inform policy more generally. But right now, that is the policy, that's correct. There's a second question about COVID, which is, my daughter's 22 years old and has Dravet with comorbid mobility issues, severe global developmental delay and autism. Always suffered with obstructed airway while sleeping or during seizures, which seems to be worsening at present. Her breathing is particularly noisy at night. Does this condition increase her risk if she were to contract coronavirus? She doesn't have any other diagnosed respiratory illness such as asthma. So I think what we are learning is that there's no reason to think that an individual with Dravet syndrome is at more risk of getting coronavirus. It doesn't seem to be associated, as far as we know, with any immunosuppression that means that you're more likely to get the virus. On the other hand, we know that if people have comorbidities, it increases their risks of having more severe disease if it occurs. So, for example, coronavirus we know can cause problems with the way the lungs work and can increase the risk of a secondary bacterial infection causing pneumonia. And if people already have comorbidities that compromise their ability to fight off infections, this is typically obesity, hypertension, diabetes, older age, then those people will have more of a battle sometimes in that situation. And we think that probably people who have respiratory difficulties, which includes recurrent respiratory infections, tracheostomy, then they may also be at greater risk. But whether the specific features that were noted in this message with an obstructed airway, I don't really know enough about that to be able to say. I think if this means, for example, something like sleep apnea, then I would think it's more likely to be the features that cause the sleep apnea that increase the risk, rather than the symptoms that are mentioned here specifically. Asthma does increase the risk of having a more severe experience with coronavirus. So I hope that answers that question. Helen, I think that's all the questions that I could see.
That's excellent, Sanjay. Thank you so much. So I'll hand over to Fiona And if anyone has any further questions, please do message. Thank you very much.
Okay, so somebody's asked a question about medication and treatment decisions for those over the age of 18. Well, it depends whether or not they have capacity to make those decisions or not. Somebody should be looking at or assessing their capacity. So the clinician, so Sanjay, one of the questions that Sanjay might be looking at, I mean, probably by the time you get to see Professor Sisodiya, those issues may well have been resolved, but certainly your general practitioner or someone, when you're looking at medication and treatment, should be looking at, does somebody have capacity to consent? If you don't have capacity to consent to medical treatment, or if the young person doesn't, then the idea is meant to be that clinicians and parents make decisions collaboratively in someone's best interests. So there shouldn't be any need for any dispute or anything like that. You or a parent, as part of the decision making under the Medical Capacity Act, parents and carers' views must be taken into account, and the clinician must take that into account and make a decision if there is a dispute. But for most situations, there is power for clinicians and anybody else to make decisions on behalf of someone who lacks capacity, providing they make them in good faith and they followed the relevant guidance of taking everything into account, without there needing to be any kind of deputyship. Now, it may well be, if there's a significant conflict or significant issues around what treatment and what medication should be provided, then either there would need to be an application to the Court of Protection, if that couldn't be resolved by way of mediation, or a welfare deputyship, if, for example, the medication and treatment decisions were tended to be ones where there was maybe a familial dispute around them, or where there needed to be a series of decisions made and really there needed to be one person who made those decisions without anyone else. But there shouldn't be an automatic presumption that just because people will need to make decisions about their medication and treatment, that therefore means you should get a welfare deputyship, if that's helpful. There's secondly a question about starting to have trouble about decisions for our son at age 17, e.g. discharging from hospital. Is this right? Well, again, it comes down to a question of capacity. You are a child until your 18th birthday, and there was a recent Supreme Court decision last year which still said, for slightly different purposes to do with deprivation of liberty, that parents could in effect give consent for their children to be deprived of their liberty, which isn't a bad thing, it's just a thing that we have to recognise. Until they're 18. However, there is also a concept which clinicians, medical clinicians know all about, called Gillick competence, named after Mrs. Gillick, who wasn't very happy about her 15-year-old daughter possibly being prescribed contraception without her knowledge. And that basically provides that as young people get older, their wishes and views may be such that they are seen as being able to make decisions on their own behalf, even if they're under 18. I have to say, however, I think the idea of a 16 or 17-year-old being the one who's making the decisions as to whether they should or shouldn't be discharged from hospital is one that I personally, depends entirely on the facts, would feel quite uncomfortable about, because I'm not sure really any 16 or 17-year-old. I think you have to compare the disabled person to the non-disabled person. Would I allow my non-disabled 16 or 17-year-old to make those decisions? Probably not. So it shouldn't really be. I think what we have to realise is that the idea of the Mental Capacity Act is to try and create autonomy for people with disabilities, but it's not meant to create more autonomy than other young people have. And I think somebody else asked a question beforehand about transition, and in effect 17 and a half, I think, which was the age which was discussed, is too late to be planning a transition to an independent home where you're looking at maybe trying to purchase a home and set up a care package. Now, for lots of local authorities, that's what they end up having to do, because the more complicated and difficult a young person's needs are, the more likely it is that the only solution that can practically be found is creating a bespoke home and a bespoke care package. And so that's the position. Now, I've then been asked a couple of questions about deputyship for financial affairs and legal documents. Well, the answer to that question is you need to go on the Office for Public Guardianship website, and they have copies of the LPAs for financial affairs and the deputyship applications. I can't remember how much it costs to make the application, but if you go on the Court of Protection website or the Office of Public Guardians website, that will tell you. And you will need, in order to be able to manage financial affairs and bank accounts, if the only money that your young person has is benefits, then you can get something called an appointeeship, which isn't something which requires a court order. It's an administrative thing that the benefits office does, the Department for Work and Pensions. So you have to provide various forms of information to show that the person isn't capable of managing their benefits themselves, and that can all be done not via a court. Otherwise, for your children and young people, an LPA is not really going to be relevant. Financial deputyships will be made routinely for children and young people like yours, because the likelihood of them being able to manage money, to be able to, you know, pay rent, pay the bills, pay the carers, things like that. I can't imagine that very many of your young people would be able to do so, although some may be able to do that. And that again means you have to have something called a deputyship. So you apply for that to the Court of Protection. It's a paper process. The Court of Protection has all the various information. You fill a form in, you have to provide some information, and you have to say who it is who's going to look after them. If you happen to have several trust funds and money in houses in Primrose Hill, then you may well want somebody independent like a solicitor or an accountant to do it. For most of you, the application fee is £365, so Helen tells me. And yes, and then you have to pay another £485 if the court decides your case needs a hearing. There aren't that many cases in which that happens. That's only usually happens when the court's not clear whether or not a financial deputyship is in your child's best interests, or when it's got concerns about who the deputy should be. But the vast, sort of 90% of all deputyship cases are decided on the papers. Yeah. And then after that, if you do become a deputy, there are various practical things you have to do in terms of filing accounts, showing the Office of Public Guardian on an annual basis that you're not spending money willy-nilly. I have had some involvement in some cases, particularly involving elderly people, where people have obtained deputyships and then used it to spend, you know, holidays in the Bahamas and expensive handbags, saying they would have wanted that, which was quite entertaining but not necessarily great. But yeah, you just have to show that you're spending the money on your child's care rather than on, you know, gallivanting around the world, and then there won't be any problems. Okay. I hope that's helpful.
Thank you, Sanjay and Fiona. I think I found that very, very interesting, and hope everybody else did. It was great to have so many people ask questions, and I think you covered off an awful lot in such a short time. I think we could have kept you here for another 2 hours, but thank you so much for your time, and it was really nice to see everybody here. So thank you, everyone.
Thank you.
Thank you all very much. Thank you. Bye-bye.
Bye-bye. Bye-bye.